problems with metabolism of estrogens. So once we look at it, really, it's basically everybody has testosterone and estrogens, and it's that balance that creates or disbalance that creates the gynecomastia in the adolescent population. Obviously, it gets very complicated when you start talking about which medications cause it. How much marijuana are they smoking? Is it still physiological or idiopathic, or is it secondary gynecomastia, secondary to smoking marijuana, or what have you? A lot of the medications that people take nowadays can cause it, and you have to figure out, is it the medication? Psych meds, for example, I've seen a lot of that. Or is it basically just physiologic adolescent gynecomastia? I've seen a number of boys with Klinefelters, and you cannot forget about that. So what are the implications? The implications are it bothers them, and it bothers them to the point, kind of like why do we get orthoplastics? We do orthoplastics in the 5 or 6 year old because that's the area, the time when kids get picked on, and when it gets noticed by the classmates. And it creates a significant amount of psychosocial distress to these young boys, especially when they're starting to do sports and they're in the locker rooms and they're playing shirts for skin. It becomes a big problem, and the social maturation actually can be disrupted. So the big question now that I have is, do we have to work anything up? So by that I mean, everyone wants to send it to the endocrinologist. And the answer is probably not, but if you have a rapid growth of the gynecomastia, you have prepubertal, okay, a 10-year-old who's not in puberty yet. Why do they get unilateral gynecomastia? Because that's something you have to look into. A large amount of gynecomastia, small testicular size, and those are reasonable areas, but the vast majority is low yield. By the time the kids come to us, they've already usually been worked up. The pediatrician sends them to the endocrinologist sends them to us. Everything's basically normal. In PRS just this year, it confirms that. There's really no need to do an extensive workup. I do believe the physical examination is the most important part. I think a testicular examination is very important. It's uncomfortable for the patient, it's uncomfortable for the doctor to examine a 15-year-old's testicles, but it's important. And as they get a little older, 18, 19, in their 20s, that's the area you have to start thinking about testicular cancers too. So you just, a physical exam is important. A dominant mass is important. Most of the time they have gland, it's dense, or pseudogynecomastia, meaning fat. But a dominant mass needs to be worked up. Generally, I don't think I've ever seen one in an adolescent population. But yes, you have to do a good physical examination. And plastic surgeons love classifying stuff. And the idea of classifying things is to say, this is class A, therefore this is the treatment. This is class C, therefore this is the treatment. I don't think it's so clear-cut. The issue is, how much excess skin is there, and is it of good quality? How much fatty tissue is there? How much glandular tissue is there? And what kind of result are you going to get with that in each patient? So I never look at a patient and say, oh, they're class 2, they need this operation. You individualize it based on what the breast looks like, what it feels like. Skin quality is probably the most important thing. So how do we manage these kids? You know, you can put them on drugs, you can take them off the potential inciting factor, but surgical management is what we mostly are talking about. And I look at the volume of the breast, and I've seen 15-year-old boys, usually obese, with D-cup breasts, right? Ptosis, and again, I think the most important thing is the quality of the skin and how much excess skin they have, the density of the gland, and weight gain or weight loss. So when these kids have not been, when it bothers them, because there are some kids who aren't bothered at all, and there are some who are bothered by a tiny bit of it, and they're saying, really, what are they worried about? But basically, when it's causing psychosocial issues, and when the patient has had non-resolution for 18 months, usually 14, 15 years old, sometimes 13, but generally around that. And that would be a patient for, I would think, as long as everything else, all the boxes are checked, would be reasonable to do. I bring in financial issues because I've had one patient covered for gynecomastia excision, and that was a patient with schizophrenia on psych meds, and that was the only one that I got covered. I don't know if anybody gets this covered. I don't. And I tell that to the patients, I tell it to the families, because even if the patients come in and say, but doctor, it's causing him all this distress. I'm like, well, I know. It's not going to be covered. I don't have much luck with that. For me, it's the skin. This is the skin. The skin is everything. So the skin is really what dictates what we can get away with. And sometimes I say get away with, because if you're going to push the envelope, you have to discuss with the patient what you can get, quote unquote, get away with. So ultrasonic liposuction. When I was a resident, this was it. Dr. Warwick, who obviously we don't have to say how successful and amazing he's been. The UT Southwestern group came up with the only treatment for gynecomastia is ultrasonic liposuction. That's the standard of care, and everything else should go from there. And then they also stated that once you do it, if there's still excess skin, the skin resection is going to be smaller when you do it after in that second stage. And I don't think I've noticed that at all. And if you look at this result here, this is a result of a guy who's got excess skin, glanduloptosis, poor quality skin, and ultrasonic liposuction was the wrong operation for him. And in this article, they didn't publish the result after the skin excision. So do I think that the second stage operation, the skin excision would have been less because of the ultrasonic liposuction? My opinion is no. So this patient needed some sort of skin excision primarily. They didn't get it. So ultrasonic liposuction was, and still in the literature, is oftentimes cited as the gold standard for gynecomastia, and I'm not sure I agree with that 100% of the time. Also, who here still has an ultrasonic liposuction? Okay, got one. Ours broke a couple years ago, we still haven't replaced it. So we just don't use them as much. I have no experience with laser liposuction with gynecomastia. I would assume it would be the similar type of concept, but it's a skin thing. And I don't believe that heating the skin with a laser is going to contract the skin as much as many of the times we see it. This is something I'm doing more and more of, although not on every case. This can work really well. So you use an arthroscopic shaver. This one's made by Stryker. They have different versions of them. You hook them up. They've got aggressive. They've got not so aggressive. And you liposuction the fat, and you actually shave out the gland. And this can work really well. Now, the advantages that we say is because, and I'll talk about how I generally do with gynecomastia. These operations, in theory, are minimally invasive operations. I will tell you, the first one I did, I got a massive hematoma. So, and it's not easy to drain through those small holes. So, you are cutting out the breast gland despite tumescence. There is a learning curve. How aggressive can you be? How aggressive do you want to be with it? Which device do you want to do, technique-wise? And this is something everybody should think about. It works really well, but there is a learning curve to it. And it's not complication-free. And if you have a lot of excess skin, that excess skin is not going to be treated by this. So this is from that article. I didn't do this, but it shows you a wonderful result. I can guarantee you I could have gotten excellent results as well, no matter what I did with this kid, right? Nice skin quality, tight skin, no ptosis. This is a kid, the only thing that I think will not really completely treat it, I think would be ultrasonic liposuction. Because this is, you all felt this, like a golf ball under there, right? Doing any sort of liposuction alone is like sucking a milkshake through a straw. It's just not going to come out. So I think that this is a kid who most techniques are going to give a good improvement on, right? Direct excision is basically what I do. I know that the complication rate is higher. I know that they likely need drains. I know that the hematoma rate is going to be higher. It's just predictable. And it's not a small operation. I mean, it's a subcutaneous mastectomy. I'm taking the whole breast out through a 2-centimeter incision. And it's an operation that plastic surgeons do and general surgeons don't. Everybody with excess fat does get liposuction to feather it out. A lot of times I don't. I used to commence the breast and use sharp dissection, and the hematoma rate was so high, I just started using Bovie, and I just use a Bovie now under direct division. If you have skin excision needed, you got to talk to the patient about the skin excision ahead of time. Whether you're going to stage it, whether you're going to at the same time, what pattern of skin you're going to remove. It's a trade-off. Everything's a trade-off for scars, for the shape. And if they have excess skin and you don't take out the excess skin, they're going to have redundant skin. And they have excess skin and then you're going to take it out, they're going to have a scar. So that's a conversation y'all have to take. Now this is a standard case, periureteral result, and I still have a little bit of residual. I also found that, I was trained and I still, for the most part, did leave about 2 centimeters of subglandular or subareolar gland to avoid a quote-unquote saucer deformity. And I found that I often got this a little bit, not bad, good result, happy kid. When you want to get, and this actually looks probably more natural than if it was completely flat. But I do think that sometimes the saucer deformity is due to not removing the excess skin, and the excess skin is redundant around the areola as much as it is leaving the excess skin. So I don't leave as much excess skin or excess gland under the areola that I used to. Again, another case, very predictable. These are all direct excisions. Now this case, no matter what you do, you would have got a good result, right? This is unilateral. I think that the 3/4 views for any of my breasts tend to really show the breast and the results better than just a straight on view. And this is a guy who's unilateral and is, as you can tell, very happy with himself. Again, another one, direct excision. Now when you start getting to a little bit of the extra skin, this is one of Steve Nar's cases I stole. When you're starting to get, you gotta remove the excess skin. Complete subglandular mastectomy, deepithelialized excess skin. The excess skin, you can see he's removing several centimeters of skin in this area. This is an operation to do more and more and more. This is an operation that even for transgender patients can be very powerful. But if you didn't remove the excess skin, he would have an inframammary fold, no matter how much you break it up, and the skin would be hanging caught over that fold. This is a kid who is a BRCA1 positive. Actually, his father unfortunately had metastatic breast cancer. So it was sent to me by the breast surgeon, and I performed that operation. This was literally the same operation you would do in a patient with genetic predisposition to breast cancer who was a female. The whole breast comes out through that incision. This is something that general surgeons don't do, right? This is another case that you have to have a discussion with the patient, right? This is a patient who probably needs skin excision. The patient doesn't want a scar. You can clearly see the excess skin. Now it's not hanging over the fold because you break up the fold, but it is hanging internally around the areola. Excess skin. So you can come back and you can cut it out circumferentially around the areola or what have you. But if you don't address the excess skin in that first operation, you have to be prepared to do revisions. This is one you can see made like a periureteral and a lateral. It's just kind of like a vertical breast reduction, but it's made laterally. The guy with the hairy chest tends to do pretty well. This is probably a 19-year-old, I think, who's in college, big guy, and pretty happy with the result. You can get away with the scars a little bit more with the guy with the hairy chest. Unfortunately, when you get to look like this, you need a scar. And in this case, I don't always free nipple graft them. If I can, and I use a little inferior pedicle, I think it looks way better than a free nipple graft. But you got extra skin, you got to take out the skin, right? I alluded to it before. I'm not so sure that staging the skin excision decreases the length of the scar. I've never seen any evidence to that, and certainly in my experience, with few exceptions, maybe it's 1 centimeter, maybe 2 centimeters shorter. There's no way to really measure that. So if you're going to cut out the skin, just cut out the skin. Again, another one, excision in the lateral. And this goes to show you, as far as tuberous breast is concerned, that males get tuberous breasts too, right? And again, another one, this is an undercorrected patient. This is a patient who needed even more skin resection than that. Happier patient, but to you and me, best aesthetic result? No, not really. Even this guy, massive breasts, right? Free nipple grafts, big excisions, is it the best result? Not really. Also, it's because when you start good, you end good, and when you start not so good, you're not going to be perfect. So weight loss is very important to talk to about it and what have you. So the one thing that I've realized over the years, and I still stick to it, is if you can do an operation for gynecomastia and not leave the patients with a visible scar, it is a tremendously satisfying operation. But if you have to leave the patient with a significant scar, it's not so satisfying, at least not for me. So that's kind of like my spiel on kind of how I handle gynecomastia, and hopefully somebody will learn something.
aesthetic nose in the adolescent.
Can I have my slides up? So, you know, doing rhinoplasty, septal rhinoplasties is probably difficult on a patient-physician relationship. And it's something even more difficult when you're dealing with adolescents. We'll talk a little bit about that. So, you know, a caveat even before I start this talk is that, you know, look, we're not trained as psychologists or psychiatrists, but you get a gut feeling. And you get a gut feeling not only from the patient, but you get a gut feeling between the patient and the family's relationship, the parent relationship. So as I get more mature, I actually get more conservative. And this is what I've heard and trained from my elders and my mentors. And when I was younger, I was more aggressive. But as time goes on, if I or my assistants get a gut feeling, I tend to shy away from it. But needless to say, I'm going to talk about pediatric and adolescent functional septal rhinoplasty and some of the caveats and guidelines that I've learned over a few years. First of all, you know, the nose is not just a tube for airway. I mean, there's a lot of things that go on in the nose that I don't think usually appreciate. You know, besides heat exchange and humidity and air passage, you know, there's also sort of the nasal resistance that's very important, and the positive end expiratory pressure that's needed to keep our alveoli open. There's certainly the immune system, the first part of the immune system of our airway, in addition to multiple reflexes and the quality of voice that we all know doing palate surgery. The nasal volume and airflow, as I always teach the residents, you breathe not through the nose this way, but you breathe straight back. And so the inferior turbinate and its effect on resistance is very, very important. And just partial and minor changes in that volume of the inferior turbinate can change a lot of the airways in addition to any septal correction, probably more so than septal correction. So when you're looking at nasal airflow, especially at the area of the internal valve, which is the first constrictor in the area of our airway after the vestibules, then you know really look at the turbinates at that point there. So the key is children are not small adults, okay, and you shouldn't look at them. So as you approach, you know, functional septal rhinoplasty in somebody that's in adolescence between anywhere from 5 to 18, just remember it's different, and I'll explain why, both physiologically and psychologically. First of all, the facial skeleton, the upper third grows very rapidly. We all know, being craniofacial surgeons, that in the first 2 years of life, you have that, hyper-accelerated growth secondary to the functional matrix of the brain. But the lower third also grows fairly rapidly, but not as much, okay? The middle third is really based on how it grows through those different growth centers, those osteomembranous growth centers, but also through the paranasal sinuses. So these are some of the key points, okay? At 8 weeks into uterine, you're going to have several intramembranous ossification centers. The vomer, medial pterygoid plates, nasal bones, lacrimal ethmoid system, which is one and the same, and the medial sphenoid area, especially near the base of the skull. We always talk about the vomer, though, don't we, when we talk about cleft palate surgery and cleft palate nasal surgery. The key is there's some action in there, and it really truly ossifies not until we're full adults, the age 21 and 22. So remember that as we go along in this lecture. There are two important cartilages that continue to grow very, very late, okay? But it first starts, obviously, in the embryonic stage. And if you look at it here on this slide here, it starts really at the posterior occipital area and goes all the way up to the septal cartilage. It's kind of one union. And it goes across the basal-occipital area into the spheno-occipital area, the skull base here, spheno-basal area, into the cartilage. That is contiguous as one piece of cartilage. And so any changes of that early on, and the earlier the changes, you can really change the shape, especially near the area of the skull base. There's also the interactions to the nose, in particular scar. And we know that scar has a lot of effect on the area of the mid-face growth. In addition to the nasal spine, the intermaxillary crest, the anterior premaxillary area, and around the area of the piriform. And we've seen that over and over again when we cause scarring from cleft lip surgery, but also scarring in perinasal surgery, that there's secondary effects onto the area of maxillary growth, which contribute to the base of nasal growth. So what are some of the anatomic differences when we're looking at children? Well, first of all, they're cute. They have a wide, obtuse nasolabial angle. That's what makes them cute. And they have that little button upturned nose. They have less projection to the tip as compared to the dorsum. It's not that 66th percentile, that 2/3 of a projection versus length of the nose. It's a little bit shorter than that. They have greater cartilage to bone ratios in the sense that you have more of the upper lateral cartilage as compared to the nasal bones and the frontal process of the maxilla. The septal cartilage actually can extend and actually replace the inferior portion of the perpendicular plate of the ethmoid, which is being formed at that time. It can extend all the way back to the skull base, to the sphenoid region. And that was depicted at that previous slide and how that changes with growth and with age. And then even the upper lateral cartilages can extend not just underneath the nasal bone, the paired nasal bones, but they can extend all the way up to complete underneath those nasal bones. So that's another consideration, but they regress gradually with age as the nasal bones don't grow anymore, but the rest of the nose grows more anteriorly with the cartilage. And then the ethmoid perpendicular plate is absent. That's usually cartilaginous and younger. You've seen that if you operated on cleft lip nasal rhinoplasties, and you've noticed that you're actually taking more cartilage out than later on. And as you age in an adult, when you do that, you have to address the perpendicular plate, the ethmoid, and part of the vomer. So they fuse at the vomer level around 5 or 8 years of age. That's when you start seeing that perpendicular plate in that junction. So based on that and looking at the literature, so what? So what age is safe? And that's where the controversy lies. So where is the optimal timing? So it's the argument, are you really creating some type of inhibition to growth, midfacial or nasal growth?